Hello. Hello, can you see my screen and can you hear me?
Yes,
Hello.
sir.
Yes, okay. Okay, we'll start then. Today I am going to deliver two topics. One is going to be the principles of pulse oximetry, and the other one will be the principles of capnography. So they are not going to be very long lectures, so it's going to be very short lectures. So first we'll do the pulse oximetry and then see whether there's any questions related to that. And then we'll have a 5 minutes break and then we'll do the capnography. Definitely it will be finished before the 2:30. Okay, right. When you consider the pulse oximetry, it shows the percentage saturation of the hemoglobin with oxygen. And it is one of during the last few decades, it became the standard for continuous monitoring of arterial blood gas levels in non-invasive method. And it also includes as a minimal standard of monitoring in the NICE guidelines. And when you see the differential absorptions of different types of hemoglobin at different levels of light, different wavelengths, when you use the different wavelengths, the absorption pattern is different. So when you plot a graph against the absorption and the wavelength of the light, you will see a graph like this for methemoglobin, hemoglobin, oxyhemoglobin, deoxyhemoglobin, and carboxyhemoglobin. The graphs are plotted. So they are having different absorption bands. So this difference is being used to assess the percentage saturation of the hemoglobin with oxygen. So what we do is a sample of light is radiated through the sample and determine the quantity of absorbed radiation. And for this, we place the probe in a place where the vascular density is high, such as in fingers, which is usually, and we can use in the toes, and also earlobe and nose. Those are the common sites that we use to measure the pulse oximetry. And then after the measurement of the absorbed radiation, and then there will be a quantitative measurement using a spectrophotographic measurements. When you consider the pulse oximeter, the advantages are it is transcutaneous and non-invasive, it's relatively cheap, and it has a compact device, and we can measure it continuously, and it will show desaturation before the clinical cyanosis. When you consider the components of the pulse oximeter, we have a light source, which is usually a light emitting diodes, which emits a specific range lights. And then there will be a light detector, which is a photodiode. And we have to use a kind of opaque probe to minimize the effects of the ambient light. And we use a single amplifier and a noise filter and also integrated circuit controller and signal processor to find the final calculation. And uses user interface with a graphical display to display the final graph and the value. and there should be alarm systems. And we used infrared and red lights emitted by the light source. The infrared is on 940 nanometers wavelength, and the red light is 660 nanometers in wavelength. We use these two colors because they can penetrate the tissues well than the other colors. Usually this LED fires at a rate of 30 per second in most of the pulse oximeters, but in latest versions, they are firing very faster, much faster, maybe up to hundreds. So it's like this, a red light, then the infrared light, and there will be a pause. Like that, it rotates. And according to this picture, you will see that the red light and the infrared light will goes through the tissues of the finger, and some of these lights will be absorbed by the hemoglobin and deoxyhemoglobin. And the remaining light is detected by the photodetector in the other end. So this absorption is depend on two main laws. Those are called the Beer's law and the Lambert's law. So the first we'll go through the Beer's law. It mentioned about the concentration of the light absorbing substance. It says the amount of light absorbs is proportional to the concentration of the substance. It is the Beer's law. So in real terms, it says the intensity of the transmitted light decrease exponentially as the concentration of the substance increases. So that means when the substance concentration, oxyhemoglobin or the deoxyhemoglobin concentration rises, it will absorb more light, and therefore the transmitted light will be decreases. And when you come to the Lambert's law, it is basically the length of the light path. It says the amount of light absorbs is proportional to the length of the path that the light has to travel through the absorbing substance. So you will see that with the arterial pulsation, during the systole, the artery will expand, increasing the length. And during the diastole, the arteries will kind of a constrict, the length is less, reducing the length. So that's how the Lambert's law applies there. So in scientific terms, the Lambert's law states that the intensity of the transmitted light decreases exponentially as the distance traveled through the substance increases. Sorry. So detection of amount of oxyhemoglobin and deoxyhemoglobins will depend, which depends on the Beer's law, is like this, according to this graph. So you will see at 660 nanometers, that is the red light, the deoxyhemoglobin absorption is higher than the oxyhemoglobin. So at the infrared, it will be other way around. Right? So if you want to remember this thing, so what I usually, how I remember this is now, when you consider the oxyhemoglobin, it's bright red, right? So that means it is reflecting, it's more red light. That's why we can see it as bright red. So the the absorption of red light is less in oxyhemoglobin. So you can remember like this. So in the other part, other way around. That's how I remember. When you are, if at any point, if you ask to draw this graph, you can draw this in a kind of a very uh, rough way, but you can use that methods to remember that. Okay. So it's very important to detect the pulsatile flow because several tissues other than the arterioles, the hemoglobin and the oxyhemoglobin and the deoxyhemoglobin absorbs these lights. So we need to differentiate that. That is where the Lambert's law become important. So as mentioned in the slides, the infrared and the red light absorption from tissues other than the red blood cells can interfere with the results. As I mentioned earlier, the arterial blood volume changes during diastole with increase and decrease during the diastole. So that is the length that passes through will change. So that means the infrared and the red light absorption changes during the cardiac cycle in the arterioles or the arteries. Blood volume within the veins, capillaries, skin, bone, and soft tissues remain constant during the cardiac cycle. So therefore, it's important to measure these changing absorption in the arterioles and the non-changing absorptions in the other tissues separately to differentiate the oxyhemoglobin and the deoxyhemoglobin. So it's like this. In the picture in the top, you will see that the changing absorption, variable light absorption due to the pulsatile arterial blood volume. It is called the AC signal. The DC signal comprises the constant light absorption due to the non-pulsatile arterial blood volume, the constant light absorption due to the venous blood volume, constant light absorption due to the other tissues. So when you see this picture, you will see that the changing absorption, the AC signal is only a very small percentage of the total signal. It's usually about 2 to 5% of the total absorption. So the important part is only that 2 to 5%. So we need to ignore the non-changing absorption during the calculations. Now, usually, if in theory, the room light or the ambient light can affect the reading because that also can affect the final detection. So usually that is why there is a pause in between the red and the infrared light sources. So it is considered as a dark signal. So if everything, all the other parameters are the same, so the machine can reduce that dark signal from the final counting because it's going to be common for both the occasions, all three occasions when it's called a dark signal, right? So when during this is a very complex calculation that they do to do the final saturation value. But in the computing, that they will measure the infrared light absorption, then they will measure the red light absorption, correct the non-pulsatile flow absorption, correct the ambient light effects, and they are using these values with the final to get the final calculation. They use the complex equations and calibration graphs, and will get average value for the last 8 to 10 readings before displaying the final result. That's why you don't get the pulse oximeter reading immediately after you put the pulse oximeter. It will take about few seconds to display the final value because they are taking average values. Value as a SpO2 and show a pleth, which is called a plethysmographic trace. It is the graphical trace of the change in pulsatile absorption, which I talked few minutes ago. As we mentioned that this pulsatile absorption is only up to about and there's another term called PI or the perfusion index. Especially this was shown in the the small pulse oximeters available during the last few years. It is the ratio of the pulsatile blood flow to the non-pulsatile static blood flow in patients' peripheral tissues. So it can be considered that PI equals AC over DC into 100%. It indicates the pulse strength at the sensor site. And it gives a clue on the peripheral vascular tone. So when the vessels are dilated, you have a higher PI index or the perfusion index. You can see when if you apply this pulse oximeter to an arm that where you are going to give a regional block, or if it is in the leg after the spinal anesthesia, when the area is vasodilated due to the local anesthetics, you will see that the PI is increasing. So that indicates your block is working. Your sympathetic activities are diminished by the your peripheries, your local anesthetics. So this PI is being used to assess the effectiveness of the local anesthetics in studies very recently. And there's another thing called isobestic points. These isobestic points are the two values of the hemoglobin and the oxyhemoglobin and the deoxyhemoglobin curves, where the absorption of is similar. So those are considered at 590 nanometers and 805 nanometers. So at these 2 points, if you use any of the lights which corresponds to these nanometer wavelengths, you can't differentiate oxyhemoglobin and the deoxyhemoglobin. So it can be used, if you are using the isobestic points, it can be used to quantification of the total hemoglobin concentration. Okay, so what are the limitations of the pulse oximeter? Now, these calibrations are done using voluntary individuals, healthy voluntary individuals. Make them hypoxic and then measure the values and use for those graphs. But ethically, we can't desaturate them beyond certain limits. So because of that, below 75 or below 70 of saturation, most of the values are extrapolated according to the other values. So therefore, we don't know whether the low readings are correct or not. So the low readings are not reliability is low. So there can be problems of movements, and because now we know that the changing absorption is a very, very small percent of the total absorption. So if this portion gets lower, our measurement systems getting problematic. So if the hand is moving, it will give a false results. Same as the thing called optical shunting. If the finger is not placed properly, or if you are using a wrong size probe, we might not get the proper reading, because again, the reason is the reduction in the changing absorption, which is only a small part. So if you have a too much ambient light, too strong room light can submerge with the signal detection and then lead into non-reliable readings. I think most of you may have observed that when you take the pulse, when you put the pulse oximeter, and then when you try to put a cannula to get the theater light closer to the hand, you will lose your pulse oximeter reading. Because some of the machines have this problem. So you can minimize this problem by removing the strong light away from the detector or cover the probe. But usually the advanced proper machines using proper technology don't have this problem. And you can have an electromagnetic interference. Now, electromagnetic fields created by instruments such as basically diathermy. So as shown in the picture, their current can go through the wire connected from the pulse oximeter to the computer, and then altered the signal for computing, changing the result. So this is called the electromagnetic interference. And poor peripheral circulation, because you know that if you don't have a proper circulation, reasonable circulation, the pulsatile flow, the changing absorption is going to be less, which affect the AC signal of the pulse oximeter waveform detection, will give rise to a false reading. So this can happen with hypertension, shock, hypovolemia, hypothermia, peripheral vascular diseases, tight plasters, BP cuff, tourniquet, anything similar to that. Ear and nose probes are more sensitive to peripheral shutdown than the finger ones. And when there's a venous pulsation, we are not supposed to have the veins pulsatile, but if there is a venous pulsation, it can interfere with the final results because we don't measure the venous pulsation, such as in severe tricuspid regurgitation. And if the probe is in a dependent position sometimes, or tight probes, might produce low readings. Dyes and nail polish such as methylene blue, indocyanine gray, dyes such as those can show artificial low readings. And nail polish also can affect the accuracy. For abnormal types of hemoglobin, so in the usual pulse oximeter method, we measure only the oxyhemoglobin and the deoxyhemoglobin. So unable to measure the other types of hemoglobin. So the important two varieties are the carboxyhemoglobin, which is seen in smokers, and also, if possible, carbon monoxide poisoning, and also methemoglobin, which can be a congenital problem, which be affected by several drugs. So if these things are present, your final result may be affected. So in smokers who are actively smoking even before the surgery, you might not get the proper pulse oximeter readings. So in case of these things, we might need the co-oximeters, where they use the additional types of uh, hemoglobins assessments, and also might need to ABG value to get the correct oxygenation values. Sorry. And the other limitation is it's don't give information of the oxygen delivery. But basically, the oxygen delivery depend on the one other parameter is the hemoglobin. So oxygen delivery is calculated by the following formula. The oxygen dissolved in the oxygen and attached to hemoglobin separately. And depending on if you calculate them, depending on the hemoglobin levels and the saturation levels, you will see that it differs. So oxygen pulse oximeter alone doesn't give a clue about the delivery of oxygen. It gives only about the percentage saturation of the hemoglobin. So you can see the chart which I was given in the bottom of this slide. And in severe anemia, because I said that these graphs are plotted using healthy individuals. So in anemic patients, we don't know whether these reports are correct or not. And it doesn't show hyperoxia. So at PaO2 of 100, it will show 100. PA2 of 200 also it shows 100. And even in PA2 of 400 also it shows 100. So hyperoxia is dangerous. So it's very important to titrate the oxygen with other measures to avoid the problems of hyperoxia. Now, when you see the desaturation process, You will see initially it drops very slowly from 900, 96, 99, 98, 97, 95, and then it gradually starts dropping very quickly. That is because of this, the shape of the oxygen dissociation curve. Early phase, it drops slowly, and later it drops fast. It's not because of the desaturation happens in the lung is exaggerated. It's the same process, but shows very quickly because of this shape. Because you need to understand during a patient, when the patient is desaturating, you must expect, if you don't correct the problem then and there, the saturation will drastically drops when it drops below the 90s. And also the other way around, when you correct the problem, when the saturation start picking up, you will see that it will pick up to about 90 very quickly and then slowly after that. This is not because of your process or the pathological problem. It's simply because of the shape of the oxygen dissociation curve. And then there will be a delay in display. As I mentioned, it will take about few seconds for the to get the average value for the final listing. So it has a machine delay. And there's a physiological delay. That means the desaturation occurs at the pulmonary level, but those blood samples should need to come to the arm or the any other sites that we are measuring to show that detection. So there is a physiological delay. So you need to think about that also when you are handling with the desaturating patient. So these readings are not usually affected by bilirubin or the fetal hemoglobin percentage. Regarding bilirubin, I think during the last few years, different occasions, some of the candidates asked me whether this regarding this bilirubin, because some books says it's been affected, Kiela, but I think almost all the standard textbook recommended mention that it's not affected by bilirubin. So you can consider that as a fact. But latest advanced technology can able to reduce the problem, some of the problems that we encountered, especially the problems of movements, problems with the nail polish, problems with the ambient light and the electromagnetic interference caused by other instruments. And we can use oximeters, uses the same principle, and use multiple lights in different wavelengths, and they can detect the carboxyhemoglobin and the methemoglobin also. And also we can use blood gas analyzers to assess the oxygenation by a different method. Any questions? Okay, I think it's 1:37. We'll come back at 1:45 to discuss on the capnography. Or at the same time, if you have any questions, put it in the chat box. So the detector will detect the amount of infrared reaching it and show it on the display by computing and measure the final values. So it will display a waveform, which is the capnogram, and display a value, which is the EtCO2. There's a thing called collision broadening, which you need to understand in relation to capnography. When a mixture of gases present, the absorption band become wider for the specific gas. So this is the normal, but it will be widened when the mixture of gases are present in this thing. It is due to when other molecules collide with the carbon dioxide slightly alter the way they absorb infrared radiation, broadening the absorption pattern. Because of that, oxygen, nitrous oxide can affect the absorption of infrared raised by the carbon dioxide, leading to some potential errors. And modern analyzers measure the amount of oxygen and N2O available in the samples and use for corrections and abolishing the problems of collision broadening. So if you can see this chart, the source will eliminate the infrared light or the rays. There will be a filter that into a very narrow range of wavelengths, and those are the only that pass through this filter, and then they goes through the sample. Some of them will be absorbed, and the rest will go and detected by the detector, and there will be a calculation and computing, finally displaying the capnography. Now, there's another concept that we need to emphasize when we are talking about the capnography, that is the response time. Now, in ideal measurement, the measurement, when you put that probe into the patient, immediately they will show the within microseconds or without any delays, it should be able to show the value. But in real life, this doesn't happen. It will take some time to respond to the signal. This delay is we call as the response time. And the response time can be divided into two factors. One is the transit time and the rise time in relation to capnography. Now you see this is the this graph in the right hand side. You will see that the orange line shows the actual value. The green one is the recorded value. And the time is in the x-axis, right? It will take some time. When the response is there, it takes some time to show that response in this thing. So this time taken from the actual happening to the display value, that is the response time. Right? So now we'll go to see what is transit time and what is rise time. Right. Now transit time is the time taken by the carbon dioxide to travel from the sampling end to the analyzer. It will take some time to this traveling. So you will see in the right-hand corner, there's a small picture. You will see that yellow globe-like thing, ball, which is considered, we can consider that as the carbon dioxide. So it has to be traveled to the chamber to get the value. So this traveling takes time. This is called the transit time. At that point only, they will start developing the response to the uh, carbon dioxide. So we can reduce this transit time by using a short tube, by using a narrow sampling tube, using a high suction flow rate in the sampling tube, or using a mainstream analyzer, which we'll be discussing later. Okay, so this is the transit time. When you come to the rise time, even when the carbon dioxide levels reach the analyzing chamber, it will take some time to show the final value. So that is the rise time. It is a time taken to respond when the carbon dioxide enters the analyzer. Or it is the time required for the display value to rise from the baseline to the maximum value. Now in theory, it's not a straight line as shown as below. It's a kind of a sigmoid shape value. It's a type of a complicated calculation. Therefore, if at any point, if they mention about a response time, it usually tells the time from the 10% of the final value to the 90% of the final value. Right? Now we'll go to the side stream and the mainstream analyzers. So in side stream, there are two types of capnography analyzers. I think people who have done anesthesia, I think you have observed this. For the others also, there are two types of capnography analyzers. One thing is the side stream. In side stream, the analyzer is away from the patient. It is in the main unit. A long narrow tube connected to the T-piece adapter at the patient end to the analyzer. So this tube will take sample from that will analyze continuously as well about 50 to 150 ml of per minute from the circuit, which includes the anesthetic gases. These gases may either return back to the system or can be scavenged to the scavenging system. So this is the side stream analyzer. And advantages of the side stream analyzers, they are not bulky at all. They are relatively cheap, and they kinked ET tube or obstructed sample lines. So sudden drop to the baseline. Extubation, disconnection, complete obstruction can cause like this. So what are the causes for gradual rise? Can be due to hypoventilation, peritoneal carbon dioxide absorption in laparoscopic surgeries, gradual increase in the temperature, again malignant hyperpyrexia, shivering, early respiratory decompensation in DKA also can be seen like this. And in sudden rise. Release of a tourniquet, sodium bicarbonate injection, sudden increase in cardiac output. Elevated baseline. What are the reasons?
Rebreathing.
Yeah, it's rebreathing, maybe inadequate flow or solder-lime exhaustion or faulty valves also can cause this. Curare cleft. It's from the when you are weaning off from the muscle relaxants, or sometimes pressure on the chest by the surgeon, or sometimes diaphragmatic movements also can show this kind of curare cleft. So this is called the inspiratory notch. It can be due to the strict inspiratory valves. Poor plateau or the shark fin appearance. So what is the reason for this? You can't differentiate the phase 2 and the phase 3. So in the bronchospasm, it's very easy to identify bronchospasm by this graph. And when you nebulize the patient or treat the bronchospasm, you will see the reverse of the graph. So bronchospasm is the common cause. Or kink tube or strict expiratory valves, cuff herniation or foreign body in the airway also can show similar things. And no plateau at all. The reverse shark fin, or can be due to the leaking ET tube or tracheostomy tube, deflated cuff, or too small airway. If you are using the too small airways, you can see something like this. Double plateaus is due to unequal emptying of the two lungs. So when the tube is touching the carina, you can see something like this, or sometimes endobronchial intubations. What is this called? So they are called the cardiac oscillations. So yeah, basically you will see these things in small children when the cardiac oscillations represents the respiratory gas, this thing oscillations. Right. So any questions? So regarding your exams, you might get a MCQ on these topics. Write the principles of the pulse oximeter. Very rarely you get a MCQ on the limitations, but about using the Lamberts and this thing you can have it. And the capnography, yes, I think sometimes you are asking about the methods of carbon dioxide. What are the methods of carbon dioxide measurements? So that can be easily asked. And you might ask few things about the rise time, the response time, those things. So that is in relation to the MCQs. In Vivas, you might ask about these things in a part of the Vivas, because sometimes you can ask about the carbon methods of carbon dioxide measurements, which goes into the capnography or into any other methods. And you can ask about the measurement of oxygen. What are the methods that you are going to measure oxygen? And then you can divert that into the pulse oximeter or the blood gas analysis or the oxygen electrodes or the carbon dioxide electrodes, whatever it is, right? So those are the things that you can ask from the exam point of view. So, and remember, during none of the exams, during the last 4 5 years, no hi-fi stuff was asked about these two topics in the MCQs, right? And sometimes in the OS case, you might get interpretation of a capnography reading or something like that. Might. It's not, I don't think that it came up during the last OS case, but it might a possibility of a topic in those case. So those are the things that can be comes to you during your exams in relation to these two topics. And I don't think that you need to know more than these things which I have explained, because I always involved in the last 3 4 years in the physics section in the July part exam. So we never asked anything other than the things included in these presentations, right? And also for any other topics, my opinion is just read the standard textbooks, right? If you are when you are looking for answers for the MCQs, if it is not correctly mentioned in the standard textbooks, that means they are not correct answers, right? Because I know that when you write these stems and the answers by remembering, you made several mistakes. And we took about 3 4 days to finalize these papers. And after that, I saw that several questions, the people who wrote those things wrote in a kind of a different way that we thought uh, of the exams, right? So don't uh, use extra time to see answers for those questionable questions, because most of the time the wording is not correct, right? So almost all, when we are preparing the questions, almost all MCQs are coming from the standard textbooks, not from journals. We are not taking anything from journals, all from the standard textbooks in physics. I think all on other papers also, any other pharmacology and physiology also the same, but it's strict to the standard textbooks, right? So that's my advice regarding to the MCQ. Okay, then. Thank you very much for joining me for these two lectures, and thank you.